Good afternoon, everyone. Welcome to today's webinar. Some interesting comments in the chat box already. Welcome to the webinar that we're here to discuss today. The topic is living well with CML. I'm Charlotte, the Patient Advocacy Manager here at Leukaemia Care, and I'll be sort of chairing or hosting today's meeting. So I just wanted to say a bit about the topic a little more, because I appreciate living well can mean lots of things to different people. So I just wanted to say, when we talk about living well, we mean anything that you feel has happened as a result of your CML that has changed the way you live your life, for example, or prevented you from doing things. And also generally talk about what you should look out for, when to seek help, what help is available, and also maybe a bit of discussion between us panelists about any further work, attention or research that's needed to specific issues. Essentially, what we'd like to do is to talk about topics that are of interest to you as an audience. So hopefully you would have seen how to ask questions in the chat function, with the rolling slides. But if not, if you're watching on Zoom, please use the chat function. We won't allow you to speak or to share your video this afternoon. If you're on Facebook, then please leave comments in the chat box, and I have colleagues who will be forwarding them over to me, so I will be able to ask those questions as well. So without further ado, I'd like to introduce my panelists for today. Thank you all for your time. Maybe we could start with you, Nigel. Would you mind just introducing yourself for me?
Hi, yes, I'm Nigel Deeks, CML patient for just approaching 10 years. I help run the CML UK Facebook group and do general patient advocacy. That's me. Thanks,
Nigel. And David?
So I'm David Fitzgerald. And with Nigel, we administer the CML Facebook page on a worldwide one. I'm also a patient advocate with CML Support UK charity.
Great, thank you. Joanna.
Hello, everyone. Really nice to see some familiar names in the chat here. I'm Joanna. I'm the nurse specialist for CML at King's College Hospital, and I've been in the job for about 10 years. And thank you very much for inviting me today. And
last but not least, Steve.
Thanks very much, Charlotte. I'm Steve O'Brien. I'm a professor of haematology and a consultant haematologist in Newcastle. I'm the old timer, I guess. I've been involved with CML for about 30 years, and I look after patients with various hematological malignancies as a consultant. The other half of my job is that I chair a NICE technology appraisal committee looking at new medicines coming to the health service.
Great, thank you, Steve. Again, thank you all for your time this afternoon. So, as I said, we're going to chat about, we've got a list of topics we could cover, but I'm very keen to hear from the audience as to what you'd like to chat to our panelists about today. So please let us know if you've got specific questions. To kick off, I've got a question to all of our panelists to start with, and it's what they think the most important aspect of living with CML is. I think we'll start with David, if you don't mind. Your thoughts on that topic, please.
Sure. So I guess, would I consider living well with CML? I think for me, that is being able to do the things that I want to do in my life, whether that's go to the gym, go to football, do my job, without having to consider my status really as a CML patient. So if I can do most of the things that I want to do, I think I'm living pretty well.
Right, short but sweet. I think that's something that everyone listening could probably relate to, the want to not let CML affect your day-to-day life. Nigel, I wondered if you wanted to share your thoughts, and be they the same or different to what David's already said.
I think David summed it up really. I think, the way to achieve that, because obviously the goal is to lead a normal life, which a good proportion of us can, of course, is by generally keeping well, full stop, trying to exercise as much as you're able to within the confines of your own life, be that because of your CML or be that because of other issues, weight, health, whatever the case may be. trying to eat reasonably well, a positive mental attitude, PMA. I think that is a massive part of it as well. And just looking after yourself, make sure you sleep well, make sure you keep on top of your drugs, and general day-to-day life stuff, really. But I do think the mental attitude is a big thing, and the fitness to help relieve the stress of not just CML but life as much as you can, really.
Great, thank you, Nigel. Steve, what are your immediate thoughts on the topic?
So I'm probably the least qualified here to talk about what the most important aspects of living with CML are, because I don't have CML, but obviously I've met lots and lots of patients over the years who do. And I think there are two simple things that I think most people are concerned about, and they're pretty obvious, but getting them right isn't always straightforward. And I think those two things are quantity and quality of life. So most people I meet for the first time when they've been told they've got leukemia are frightened they're going to die. So I think making sure that their treatment is effective and being able to reassure them that that's not the case, because that's true for the vast majority of people with CML, is a really important aspect. And fine-tuning treatments, as I suspect we'll discuss, is obviously critically important in trying to ensure a normal lifespan. But as well as that, quality of life is really important. And I think David and Nigel have highlighted that in other ways. But from my point of view as a doctor looking after CML patients, I'm conscious, I think for most people, the quality of life is fine because the treatments are well tolerated. But sometimes getting your treatment right, the dose right, the right pill, is an important aspect of your quality of life. And I think also, if you get that right, you're not having side effects, the treatment's working well, your mental well-being is better because you're not waking up every morning worrying about this condition, hopefully, because you're not suffering from untoward side effects and you're confident that the treatment is working well. So for me as a clinician, it's quantity and quality of life.
Thank you for that. And Joanna, anything you want to add on this initial question?
I mean, it's been well covered, but I would add that it's going to mean different things to different patients at different stages from diagnosis. So what living well means to you when you've first been diagnosed, or certainly in the first 3-6 months, a year, is going to have a very different focus to how that's going to be to other patients who are several years down the line. And also in terms of how aggressive disease is, you will all understand that CML has a very wide spectrum of seriousness, and to be able to focus on the things that make us all feel well: good diet, good health, good exercise, seeing friends, keeping our heads psychologically above the water, is going to be a bigger goal on some people's horizons than it is for others, for whom different questions over treatment and outcomes will be looming a little larger. So I wouldn't be discouraged if you're someone in the latter group and you think, gosh, I'm not, I'm not doing yoga every morning, and eating an entirely plant-based diet and feeling happy 100% of the time. I think that would be very odd if you were. So I think if you are able to live a life where CML isn't the primary thing in your life, and it isn't what you think about when you get up in the morning, and it isn't what you think about when you go to sleep, then you're in a better place.
Yeah, and I wish we could all be yoga-loving, plant-based diet people, but that's the nature of humans, I guess, isn't it? I just wanted to pick up on something that Steve said with you, Joanna, if you don't mind, around understanding of CML at the point of diagnosis. How long does that period often last when you're talking to patients of the shock of the leukemia? And obviously I'll come to our patient experts as well, but when you're talking to patients as a nurse, how long does that initial shock last, and how do people cope with that?
Oh, that's a very difficult question. Because of course, like anything, and health professionals will all have been patients at some time in their life as well. It's very much dependent on the individual. So there will be, some patients who will be straight online and will read everything and come and see you the next time with a research paper that's a bit over my head. And there will be other people for whom you discover several years down the line don't have a very good understanding, and because a lot of information up front is understandably too much for people. So I think it's about keeping the door open to explaining, explaining in different ways to people long term. And everyone will find their way of understanding it. And for some people, having an explanation of chromosomes being like different pairs of socks, and the socks have got mismatched and the evil socks are taking over the drawer, and we need to put our foot on the evil pair of socks and stop them infecting the other socks. That may be enough. And other people are going to want to understand how the machine that processes the PCR sample actually works. And there's everyone in between.
Yeah, no, I agree. I like the sock thing. That's really funny. Okay, so I guess coming to Nigel and David then, I think CML is both a difficult illness to understand in that it's rare and not many people have heard of it, but also it's fairly simple in terms of genetics, maybe if you think about just the Philadelphia chromosome. I mean, is it a difficult thing to understand as a patient, and does it change over time?
I think it's fairly easy to understand at a very superficial level. If we've all done, biology to some level in school, you probably know what a chromosome is, at least, your memory will be refreshed. And you'll understand that when something's swapped, that probably something bad happens. So I think at that level, most patients can understand it. I'm not sure every patient wants to understand it. Some patients want to go to their doctor and be told everything's fine, everything's going well, or everything's going in the middle and we need to do this. So I'm the kind of person who likes just hoovering up the information and reading the papers and understanding as much as I can, but that's just my personality. Other people, I think, are perfectly content with being told they're doing well and then getting on with things. And perhaps, Joanna, you had sort of a point earlier on about waking up and thinking about CML first thing in the morning and last thing at night, and that probably was me for at least a year after diagnosis. And that, I guess, wouldn't quite call an obsession, but that deep interest in learning more about it kind of kept it on my mind a lot more. And had I actually been less interested in finding all the detail, I might have put it to the back of my mind quicker.
How about you, Nigel? Are you a similar personality to David?
I think for me, the question, if I remember rightly, was how long does it take to sort of get your head around it? For me, to really feel comfortable with it was probably about 9 months, 12 months, when you start getting towards a major molecular response and knowing your numbers were low. I made a conscious decision not to Google when I was diagnosed, because my experience of everything in life is that people go online to complain about things, and people don't go online and say, hey, I'm remarkably well and this drug's fantastic. So I kept away from that. I read a fair bit when I was first diagnosed, and I think, as Joanne said, some people want to hoover it up and some people really don't want to at all. But I've said this previously, people who want to know stuff will generally join these groups and will attend these webinars, etc., because that's the interest they have in it. And that works, that works very well. I think also the biggest thing I would say is that first 3 to 6 months, it's a completely new language. I mean, I remember being told that I had got a chronic illness. So you got chronic and you got acute. And to me, chronic was worse than acute. My God, I got a chronic illness. I didn't even understand the basic difference between the two. And I think the vast majority of people, and obviously I see other fellow panelists here smiling at that, the vast majority of people really don't even have that absolutely basic understanding. So I think you've got to get a baseline, whether that baseline is actually take this pill, you're going to be all right and you're going to live a reasonably good life, or whether that baseline is I want to know everything about it. It varies from person to person. But I think for most people, you're looking at 6 to 12 months to really feel comfortable with their illness, because as much as anything, and from a personal point of view, I actually didn't believe, first of all, how good the drug was and that this really was going to work so well for me. And again, it's getting your head actually around the fact you've got a serious illness, but actually you're going to be all right, probably.
I would just say for anybody who's listening who doesn't remember doing chromosomes at school, I'm with you. I think I stopped biology at GCSE. I don't remember ever getting past labeling a daffodil, to be honest. And before I became a nurse, I don't think if you'd asked me, I was really aware that my blood was made inside my bones. So I would really reinforce the fact that if it is learning a new language, a completely new language. And you're completely right, Nigel, we don't use chronic in the same way in common parlance. We say something's chronic, we mean it's ghastly, and that's how, certainly how I would use it outside of the medical sphere. So if you're listening in and you don't really remember what a chromosome is, they're the socks.
Yes. I was going to ask what you think is important to know, Nigel, but I think you've answered that question in terms of as long as you understand the sort of basics of what's good and what's bad in terms of the chronic side of things. Is there anything anybody wants to add on what is it important for patients to remember? Nigel, please.
Yeah, no, the only thing I would just add to that, what's important, and I do think it's important, is actually having a basic understanding of the goals that you should be getting to. And the timescales that you should get them. So there's a basic understanding of what your actually illness is. To an extent, that doesn't matter. You've got an illness. What probably matters more is the goals that you should be achieving, I think, is the only bit I was going to add to that. Sorry, back to you.
No, that's fine. I think we'll come back to that because I know we've got a sort of similar topic on that, but I agree. Steve, you've unmuted. Did you want to add anything to the conversation at all?
Just a small practical thing that we've all faced in the last year or so, which is when you're diagnosed, there's quite a pressure, and it's relaxing a bit, but there has been, obviously, for the last year, there's quite a pressure for you not to come to hospital, have a telephone conversation with a doctor. I find that as a doctor very inadequate, and I'm sure as a patient that's pretty inadequate. So if you are recently diagnosed, I think at least you probably need 3 or 4 or 5 visits face to face where you can look your nurses and doctors, your clinicians in the eye and ask them questions before you're consigned to telephone follow-up. In my clinic now, I was just looking at the list for tomorrow afternoon, there's 45 patients for tomorrow's clinic, and there are 4 of them only coming to the hospital. So my point is, I think if you are being requested to have a telephone conversation, a consultation, and you've only been diagnosed recently, I think you're within your rights, and you might find it beneficial, and it's a balanced thing to get right, to actually go and meet somebody in person and form a relationship with them, ask them face to face. And then in later years, then it's much easier then to do a phone consult and much more convenient for people. I think we'll be coming back to that theme, but I think connecting with your clinicians and building a trusting relationship with them is pretty important for everybody.
Yeah, and I think that's a topic I'd like to come back to in a bit, but I wanted to pick up on the remote monitoring thing first, and maybe Joanne, I don't know whether you feel the same about, about the connection with patients and being able to have that conversation better in person. Does it work better for you that way?
Well, all the patients I can see who are listening now will know that I'm an extremely nosy person, and it's much easier to be nosy when someone's in front of you than it is when they're on the phone, and that's why a lot of nurses become so. Yes, I mean it's an interesting question, because many patients I've known for very many years, so having a chat is fine. I'd prefer to see them, but it's adequate. But I do feel for the patients for whom are more newly diagnosed, where those bonds might not have been made so deep over the years. I've been lucky so far that over the pandemic, the patients who are new patients have been relatively local, so we've been able to facilitate seeing them in person. And there's pros and cons for everybody, particularly for patients, for traveling, for the expense of traveling, for waiting around, for expensive parking. You know, there's pros and cons to all of those. And I think how it will pan out over time is that clinics will be structured over a mixture of both face-to-face and telephone.
And someone's very, very quickly they just mentioned that they don't mind telephone conversations. So clearly it is a individual discussion. David, did you want to add something to that?
Yeah, it was many years before COVID, myself and my doctor, we spoke about the need to come to hospital for all patients. And even several years ago, we felt that it is still really important to see your doctor. And so her view was that she wants to take a look at you, make sure that you're okay. And that you don't look unwell, and so we kind of felt that, you know, maybe one of every two, but you probably wouldn't want to go more than 6 months. Maybe was what we got, and then of course that was sort of 5 years ago we had that discussion, and of course I haven't seen my doctor in over 12 months, and it's just a quick phone call, and for me that's fine. I've had the same doctor for 9 years. I'd be devastated if she left her post. I have a really good trusting relationship with her. And so that allows the phone calls to be pretty easy for me. But if this was my first year of diagnosis, I'd find that really hard.
Yeah, I can imagine.
Yeah, the one thing I would just add, one thing I would add there, and I'm not particularly going to say where or what, but I'm at one of the larger hospitals, and pretty well through my whole 10 years, I've almost never ever seen a nurse or been approached by a nurse for help or whatever. And I'm sure if I had asked for one, there would have been one there, but I'm sure my experience will be mirrored by many other people. And certainly at the hospital I was at, when you did go into clinic, you just went and sat in reception. There might be 5 or 6 different hematologists on, and you got basically whoever picked up your blood report, and there wasn't actually the opportunities to particularly build a relationship with the doctor, because you didn't actually see a nurse, and you got whatever doctor you got. And if there's one criticism of the system that was there, it would have been that. And I think that as a new patient, it's very difficult for most patients, because let's face it, your doctor's God, to actually either query that with them or feel strong enough to say, I want to see somebody. So, I would just add that, because I'm sure there's a lot of other people out there that would have had that experience.
Absolutely, and it's one of the things that we did a campaign a few years ago about access to CNSs, and I think CML patients were one of the least likely to have access to a specialist nurse, and obviously that's an area of concern for us. So I totally agree with you. And if anybody is sat there thinking, oh, I'm not sure how to advocate for myself about these things, I want access to a nurse, I don't know how to go about it, get in touch with us or the Facebook group, and someone will be able to help you do that, because you should have access to all the care that you feel you need. So I think that's a really important point, Nigel. Thank you. I don't want to interrupt the flow of the conversation, but we've had a lot of questions already, and I want to make sure we cover the things that people would like to talk about today. One of them so far has been around the targets that's already been mentioned, and goals you should reach around major molecular remission. Steve, I wonder if I could come to you first just to say a little bit about what you're looking for as a doctor over time in terms of response of patients to treatment, very, very briefly, because obviously we're not here to talk about treatments today.
Yeah, there's one thing I'd really want to emphasize, which is you don't have to aim to be cured of this condition to have a normal quantity and quality of life. There are very broadly two schools of thought historically over the last 10 or 15 years. That there are the people who think that treatment-free remission with no detectable disease is absolutely the thing you should aim for, because that's equivalent to cure, and of course we all want to be cured. But if you look at most medical conditions, especially in older folk, they're not curable. Hypertension isn't curable, hypercholesterolemia, high blood lipids, diabetes. Most of the stuff we do in medicine isn't curable, but they can be controlled and lead you to a normal lifespan. So I'm definitely in the school of thought of not thinking that eradication completely of all disease at all cost is the name of the game. I think getting people into a good response with minimal side effects is fine. And if that means you take a pill for the rest of your life, then so be it. And if that was me personally, I wouldn't have a problem with that if it didn't cause me side effects. So that's point one. Point two, in general terms, the lower level of leukemia as measured by this PCR test that people will have heard about, the polymerase chain reaction test, which is basically a super sensitive test for picking up, say, 1 in a million cells. The lower that can be, the better. It doesn't need to be 0. If it's less than 1%, which is the ratio of the leukemia gene to the normal gene, you're probably in safe territory. And a so-called major molecular response, which is perhaps slightly more preferable, is less than 0.1%. So between 0.1 and 1, probably okay. Over 1, you might be thinking about a switch or doing something more about it. It also depends on the trend. So my 2 points are, you don't have to eradicate the disease to have a normal lifespan. And secondly, generally speaking, the lower the better. But we can delve into that in as much detail as you wish, Charlotte.
Great, thank you. Just to clarify, there's been a very quick question just popped up. So the PCR test is what's measuring the BCR-ABL level. Someone's just asked that, is that correct?
That's exactly right. So, it's always expressed as a ratio, because the stuff that the test is based on, which is something called RNA, is very fragile and it breaks down in your blood if it's just left on the side for a few hours. So you're measuring the proportion of the leukemia stuff, which is BCR-ABL, to the normal stuff, which is ABL. So these figures, these percentages that we talk about, are always a ratio of the abnormal to the normal, because of the instability of RNA. But yes, absolutely, it's a measure of BCR-ABL and the amount of leukemia.
So the question was around they are feeling mentally that they're finding it difficult because they've been told there is a target at which they should reach MMR. Clinically, is that something that you do sort of aim for at a certain point usually?
Yes, so there are lots of guidelines around the world, and there have been for many years, and perhaps we don't want to get into the massive detail of all of those guidelines, but you're looking from diagnosis at what the trend is downwards. If there's no change downwards, that's more concerning. But if you're going down and steadily improving, it doesn't matter so much what the absolute values are at a certain point. It's more the fact that it's improving all the time. So, we could talk about the specifics in the guidelines, but getting to a lower level is generally useful, but it's not essential. And I've got lots of patients that I look after where we try various tricks and various drugs to get them to a good PCR level. And there's a handful of patients I look after in Cumbria, for example. I do a clinic over in Carlisle where their PCRs are sort of 20 and 30%. They're not bothered about it. I keep changing drugs and fiddling about, and they're asking me, I've done this, and they've been on the go for 10 or 15 years, are fine with a normal blood count. So having a slightly higher PCR level is less common, but it's definitely not a harbinger of disaster by any means. But if you can, with reasonable tolerability of the medicines that you have to use, get the level lower, that's desirable.
Okay, so I hope that explains the reasoning for the person who was listening. But I wanted to now come to, obviously, Nigel and David. This person's talking about how they feel like they haven't, they're struggling with feeling like they have to achieve these numbers. And is that something you guys hear a lot on your Facebook groups and among those you talk to? And of course yourselves, did you feel that at one point yourself?
Yeah, we do see people get very worried about numbers, because you see treatment guidelines and you can see what's an optimal response and what's a warning and what's a failure. And people can get very worried. But I think we always try to tell people the same as Steve said: if the trend is down, then that's probably pretty good and where you want to be. I think we often see people who might say things like, actually, the goal is TFR, or my goal is 0.001. And we always come back saying, no, your goal is MMR. And as Steve said, even then, maybe that might not be exactly required for a normal life anyway. And for me, I mean, getting into TFR, I'm not in TFR. I'm not really interested in it. My goal at the beginning was getting back to a more normal life. And I said that kind of took about the guts of 12 months for me. I had a bit of a bumpy start with difficulty on drug. And I imagine for anybody fairly newly diagnosed, that's really doubly hard at the moment, because how do you get back to normal life at the moment? Even if you're doing great with CML, life's not going back to how you want it to be. So again, it's a challenging time for somebody who's newly diagnosed. But I think it does take a long while to come to terms with, you've got a cancer diagnosis. That's tough to take. And then once you sort of start feeling better and your medication is working, and you can start to do the things you used to do and not be too worried about it, and not be concerned that you can't go to the gym because you might pick up a bug or whatever it might be, I think that's when you start feeling okay about it.
Anything you want to add on that, Nigel?
Yeah, I mean, again, my journey was longer than the recommendations. For me to get to MMR, so just for everyone out there, that's 0.1%. The guidelines these days are to achieve that in a year. It took me just a shade under 2. I actually looked at some figures because I sent my latest PCR and the chart was on there, and I haven't looked at it for a while, and I'd forgotten it took me quite so long. 9 years in, my last results showed 3 CML cells. I'm at I'm at an MR 4.5. So the point is slowly catch your monkey. I was not a quick responder, but 10 years later, I'm a whisker 3 cells above undetectable. So, Steve O'Brien's mentioned it already. Don't get too hung up on the numbers. I think the one analogy I would give, and I remember it really well from a CML meeting 7-8 years ago I attended, by Professor Clark from Liverpool. And he gave an analogy which was very good, which is that when you're diagnosed, you have, let's say, a watermelon amount of CML in your blood. Or your body. Then when you get a 1 log reduction, that watermelon has dropped down to, I can't remember exactly, but let's call it a tennis ball. A 2 log reduction, it's dropped down to a golf ball, and a 3 log reduction, you're down at about the size of a pea. And I think that I found really useful, because ultimately, if you're down at 0.1 and you're down to the size of a pea, and all of a sudden it goes up to 2 peas, in the great scheme of a watermelon, it's not really that important. And I think that visualization to me was really quite a useful thing. And I hope me passing that on 7-8 years later helps other people, because I think if you can visualize it like that, it does help you get over these number aspects a little bit more.
Strange analogy so far. We've got socks, watermelons.
Yes, I was going to say, I've got a vision of a watermelon full of socks in my mind now. So.
But I think that's when we often again talk about with patients when they say, I'm really worried, my numbers have doubled from 0.04 to 0.08. And you're going, okay, but that's 4 in 100,000 to 8 in 100,000. And when you put it in absolute terms, it doesn't sound so scary.
Yeah.
It doesn't, but one of the problems with numbers is, some people struggle with numbers, and saying 4 in 100,000 or whatever, they're just numbers. And I think that if you can give a visual description, the peas or even 2 grains of sand, when you're getting down to MR4, that's where you're at. A peas reduced to, not sand, rice, I'm sorry. I think that, not for me particularly, because I'm actually quite good with numbers. I just think that visualization is very useful. Sorry, Joanna.
Now I'm feeling hungry.
I was just going to say as well, I'm thinking of another analogy now. So I drive an LD Yaris, and my next door neighbor drives a Range Rover, but he's not winning. It's not the size of it. It's not a competition. And although it is really helpful to meet others and get peer support, it isn't a competition, and everyone will be different, and there isn't a goal. And there isn't a trophy for for getting down to a treatment-free remission. You have to remember that it's not personal to you. If you don't go down to those levels, it's not a personal reflection on you. Same as getting CML is nothing you've done. probably better to be philosophical about it rather to compare yourself against others. Although it's very human to do so, it isn't helpful in the context of CML.
Sorry, just to interrupt there. And you are absolutely right, Joanna, and that's with sort of a few years' experience. The problem is when you are a newly diagnosed patient, it is a race. You want to be the fastest, you want to be the best ever, you want to do this, that. Now I'm talking as a patient now. It's a different perspective because you don't have that understanding at that moment in time. And to you, it is important to hit those goals, to get there and be the quickest person ever. And this is only where these meetings are very useful, to just reassure people that it actually doesn't matter. As long as your numbers are going down gradually or going down. So sorry.
I just would one thought as well is, for anybody fairly newly diagnosed, you're not going to feel any better at MR4 as you do at MR3. Your quality of life doesn't suddenly go up because the number's gone down. Once you've got past the initial stages, if you had a large spleen or any of the kind of initial symptoms, and once you're kind of doing well, whatever that means to you, lower numbers doesn't mean feeling better.
Yeah, I totally agree. So that's been a really interesting conversation. I know one area we did want to pick up on related was around TFR. So we did a treatment-free remission webinar in January for anybody who wants to hear a little bit more about TFR, with very similar panelists on the day. So hopefully the information should be fairly similar. But what we did want to talk about was how treatment-free remission is perceived by the patient community. I don't know if Nigel, if you would mind starting on this. I mean, is this also a problem of goals and thinking you should get somewhere when actually it's just a nice to have thing, and it should be a nice to have thing instead?
Yeah, I mean, going back to a comment I made a short while ago, you have to bear in mind that most of the people who are on these groups are reasonably well-informed patients, or want to be. The large proportion of the general public, not general public, patients out there aren't on these groups, and therefore probably don't even know about TFR. It only becomes more important when, not important, more, well, important to you when you do. I'm 10 years in. Will I try? I probably have set myself the goal of trying TFR again this year, because this is my 10th anniversary. I'm very well with my CML and don't probably need to try it, but I'm going to have a go at it. I think a lot of patients do set themselves the goal that if they haven't reached TFR or the ability to try TFR, they failed, and they haven't. I think that's key. And I think what's also extremely important is that if somebody does try TFR and has to restart treatment, you haven't failed. Because if you restart treatment, you're only restarting at 0.1% MMR, which is the goal that people aim to get to. So, TFR probably hasn't killed your CML. It's still there. It's just your body's back to keeping it under control. But it is a goal of some people, but it's not the be-all and all of it. It really isn't, and it shouldn't be perceived to be the be-all and end-all of it, because it's not, is what I would say.
Yeah. I mean, Joanna, is there anything you want to add on that from a clinical perspective? Is it something you struggle to communicate to patients in terms of it's not a guarantee, it's not a, like Nigel said, it shouldn't be the goal?
I mean, I agree. It has its benefits, obviously, in that, after a sustained period, not having side effects, being on a drug is, a very comfortable place to be. I think sometimes it tends to dominate all these discussions. And, I know for patients who are not in that rather envious position, it might be slightly disheartening. And there will be patients for whom bigger decisions are pending, and more complicated decisions are dominating their thoughts. And I tend to think it's not that helpful a main strain of any CML discussion.
And Steve, there was a question in the chat box just popped up asking if you ever I think made to try TFR is probably a bit strong. Do you ever have to persuade people to try it, or is it very much something that's led by the patients for you?
I've sort of expressed my school of thought on this, Charlotte. I'm definitely not a TFR zealot. I'm not pushing people in that direction, and I'm very relaxed about that. If a patient wishes to head in that direction, then I think my job is to support them and advise them about that. But one little point I'd just kind of emphasize that we haven't perhaps picked up on so far is that there is potentially a price to pay for getting your TFR. Obviously, as a nice chair, I think about cost of drugs a lot, but this isn't about money price, my comment, it's about side effects price. So let's say you're on imatinib and you haven't perhaps got the optimal response you'd wish, you're at maybe 0.5%. And let's say you're 53 and maybe you've got diabetes. You could switch to nilotinib, which might improve your molecular response and might give you a better chance of getting a TFR. But at that age and with that condition, the cardiovascular concerns about nilotinib and some of the other medicines are something that needs to be weighed in the balance. So, you know, all these drugs have a bit of a downside occasionally. And I think in the rush perhaps to head for TFR, I think the balance of benefit and risk with the medicine that you might require to get that TFR is a really important thing to consider.
Yeah, and sorry, Jo,
sorry, can I just add to that of course you've got to remember that it doesn't mean that the CML's gone, and you're going to have to come and the geography of your own situation will make a difference here. You'll have to be monitored every month for a few years, every 2 months for a couple of more years, every 3 months for a couple of years. So, you know, there's the downside of that as well, the traveling, the venipuncture, and again, every month waiting for a result. And that's not without its price on people.
Yeah, I totally agree. I think we've come around nicely to the next topic, which is about side effects of treatment. We've had several questions now on that. So I guess the first, and I don't want to say the most simple, but I think it's the easiest point for discussion is there's someone here saying they're on a drug, they had a really great response, but they're struggling with the side effects, and they are they say they have no other options. So, but that's sort of a side issue, I guess. The point is they're on a drug, they're reacting really well, but they're struggling day to day. I want to start with David and Nigel. Maybe David first. Is that something you hear a lot from other patients? Is it something you've experienced yourself?
Yeah, I certainly have experienced it myself. So I started off with imatinib, but it didn't really work that well for me, but it also it made me feel terrible. So we switched for that after a while, and I was on dasatinib, and it worked great. Like light speed in compared to imatinib, and how it worked, but it made me really tired. It gave me some skin problems, and so what I did over time was with my doctor was we tried to reduce the dose to just reduce the side effects, and that's worked really well for me. But I totally feel when you go and get the numbers are doing great, but I'm feeling rubbish, and that's not a great place to be. And then even when the numbers get to where you want them to be, I was still on this sort of 100 milligram full dose of dasatinib, and I was not feeling great. I couldn't do my job full time. And of course, there's the kind of worry is if I drop the dose, are the numbers going to go back up? So you have this kind of balancing game of, and I wanted to play it fairly safe, which was, okay, let's chip away at 100 to 70 and try that for 6 months and sort of see, does that make a difference? And every time we chipped a bit off the block of dasatinib, the results actually got better. I don't know the clinical reason for that, but so I've actually got my best ever results on the little teeny 20 milligram dose of dasatinib. So I think, for me, reducing dose was a really good way to get a lot of my quality of life back. And I started doing it after I was in MMR, and I've remained in MMR throughout. So I think certainly for people who are struggling with side effects and maybe who are responding really well, it's a conversation to have with your doctor, I think, about what the dose you're taking might be.
Yeah,
I think from my point of view, the side effects issue, there's two sets of side effects. I had severe leg pain and discomfort when I first started on imatinib for the first few weeks, and that's quite a common thing. After that, my side effects went, and I've said on other occasions, I'm very well. I have no side effects as such. Most patients do have side effects, though, whether they are physical side effects, be that pain, tiredness, which particularly I think is the big thing, or whether they're physical in whatever guise. And it's a very important thing. And if people are unwell, they should be talking to their clinician about them, because we do have other TKIs that can be utilised, which will make people, hopefully make people feel better, as David found. I mean, you've found a very significant difference. But I think we appreciate side effects, we being all of us in this, on this here, maybe more so than some of our clinicians do sometimes, and if you feel rubbish, tell your clinician, because if you don't tell them, they're not going to know. And I think, particularly if you're now having virtual meetings with them, that arguably might actually get harder to have that discussion with somebody. Whereas if you're sitting in the room face to face, you can often get into more of a conversation, whereas some people don't feel comfortable with the technology and therefore might want to just get off fairly quickly. You need to raise any issues with your clinician or with your support team, really, because something can be done for the majority of side effects, is what I would add.
Yeah,
totally agree, Nigel. I think there's a lot of people who get frustrated because they're told that whatever problem they're having is nothing to do with their TKI, and that may well be the case. We still get all the ailments and issues that any other person would, but I guess that's where you've got to advocate for yourself, and see, is the TKI the thing that's causing the problem? For me, as I said earlier, I didn't get on well with imatinib. My clinician wasn't convinced it was anything to do with imatinib, so we said, let's take a 2-week break. Did the kind of the half-life calculations and said you should start feeling better in 6 days if it's imatinib related, and lo and behold, it did, and that kind of gave us enough thought to go, okay, well, let's swap to a different TKI.
Can I just also add, and sorry, David, it just occurred to me whilst you were talking there, what you shouldn't, please don't do is give yourself a little holiday from your TKI because you're feeling rubbish. I think that's the biggest thing I would add, because I do know of people who've done that. They've got something come up and they think, well, I won't take my drug for a few days. You've got to keep taking your treatment. Talk to your clinician. Sorry, just a side issue, just to mention. No,
that's a good point. I guess my question to Steve then, given the conversation, and to Joanna as well, a lot of the people who are asking about the side effects, particularly about fatigue, are saying, I feel like it's not being taken as seriously as they would like. Maybe Steve first, what advice would you give to those people who are struggling with that?
I think the first thing in this odd age in which we live now of telephone consultations is to make sure your nurse or doctor hears you loud and clear. And if you're not content, you can always ask for a clinic appointment to go and emphasize the point. We've had that discussion before. Things are often easier face to face to express your concerns and your side effects than they might be on a telephone. So you're perfectly at liberty to ask for that if need be. And I think what I think it was David described, which is a quick break off your treatment, not randomly or ad hoc, as Nigel has emphasized the perils of. Don't just do it yourself. But if you've got a particular side effect and you're not sure, and your nurse or doctor aren't sure whether it's due to the drug you're on, then do the experiment. Stop it for 2 weeks or 3 weeks or 4 weeks, and if you feel loads better, then it's the drug, and you have to try something else. But you sometimes have to kind of knock on the door fairly loudly of your clinician to make sure they take it seriously and do something about it. Because if you just don't mention it or mention it casually, it's easier for the doctor to say, oh, carry on taking it, your doses, your response is fine. Just a couple of other things to chip in with, Charlotte, if I may. One is the point that David highlighted, which is increasing in the last 10 years. We just give enough treatment. We don't give the top dose. We give enough to keep people in a great response. And the dose that David described is a fifth. It's 20% of what the standard dose is. And yet for him, it sounds like that works fine. And I've got loads of patients in that situation. So if you've got a side effect and you're responding really well, you don't have to keep on bashing away at the same dose. You can trim it down a little bit. And often that's a really happy medium where your response, your ongoing response is excellent, but your side effects are much better, rather, much reduced. So this fiddling with dose question, obviously with close supervision and interaction with your clinicians, is something that is actually pretty common.
Great. Anything you want to add to Steve's comments, Joanna, from side effect point of view?
No, Steve's put it really well. I mean, I think it underlines, doesn't it, the importance of continuity where that can be achieved. And I do feel for Nigel seeing a different doctor, every single time for the first year of his diagnosis. And I think having a team that you know and trust is really, really important with that. I would also say, and I hate to sort of be a damp squid about things, that although for some people using alternative doses and alternative drugs will be an option, for other people it won't be. And then we have to sort of look at what balance we can find between optimizing side effects and making quality of your life as good as possible against making sure that the CML is kept under control.
I think one of the things people are asking about is what can be done about them if the dose reduction isn't possible. Is there specific things you can advise? I think most of the questions about fatigue, so if you want to focus on fatigue in your answer, that's absolutely fine. But are there things you can advise other than the treatment changes that would help people?
I mean, I remember having this conversation a few years ago with our really fantastic occupational therapy team and trying to put together some information about fatigue. And I know managing fatigue, and I know there is some great information out there from people like yourselves and from Macmillan and other sources. There isn't a magic bullet for it. But it is all of these, positive things that we do in our lives. And so if we can get some green space, exposure to nature, if we can keep our energy levels up by doing to the best of our abilities, walking, exercise, spending a little energy to make a little energy, if we can eat a good and nutritious diet, these are the things that we can control and are worth doing. They may not be able to take the problem away, especially if the problem is a side effect of a drug, but they can certainly help to control other factors in lifestyle. And I know this is a little easier said than done, and certainly this is a case of do what I say, not what I do. And also to remember that adult life in itself is very tiring. And if you look around and you feel that everybody else is bursting with energy and you feel like a wet lettuce, you may be surprised that not everybody is feeling like that either. But when you're feeling quite down, and especially if that's made worse by being in a situation where you feel quite alone, thinking how much of it is related to a sort of cycle of energy and mood is really important as well. And please don't feel shy to ask your doctor or nurse for help, or for signposting for help to talk about mood. That's again something that we can do and we can offer support with.
Yeah, there is plenty of it's not as readily available as it should be, but there are ways to get emotional and mental support that aren't well known, including ourselves, as my colleagues very kindly posted in the chat box. Ourselves, sorry, not myself. So if you do need that sort of help, please get in touch with us, or as Joanna said, your clinical team. Just perusing the questions a moment. I think that covers the side effects sort of questions fairly well.
Charlotte, could I just raise one quick thing, which I'm conscious we haven't discussed, which is you can get side effects when you stop a TKI. So we've talked a bit about treatment-free remission. And obviously, if you get to an excellent response and you sustain that for a couple of years and you have no detectable disease, you might want to try stopping imatinib, for example. And there are now loads of studies about that, probably well in excess of 1,000 patients of experience of stopping imatinib. And one of the curious things that came out of that is that for some patients, and again, there's lots of series here, but broadly speaking, it's about a third of people who've been on imatinib for a while, when they stop, they get aches and pains, they get musculoskeletal problems, which they hadn't have had before. And sometimes those go away when you restart the imatinib. So again, that's just something else to bring into the mix a little bit. You know, and to me, it's perhaps something on the side of not aiming for TFR at all cost, because if you get to that 0 level and you then try and stop imatinib, you've got a 1 in 3 chance of having side effects as a result of stopping that you didn't have before.
Yeah, and that's sometimes referred to, I think someone referred to it in the chat as withdrawal syndrome. So
yeah, exactly.
as a result of taking away the treatment, your body reacts to that.
Yeah.
Clinically, is that different to side effects from the treatment? Is it caused, you know, how is it different in that respect?
The honest answer is nobody knows the mechanism. In my experience over many years of treating or starting people on imatinib, it's really quite common in the first, I'd say, 2 or 3 months for people on imatinib to have aches and pains that generally settle down. And then often some form of fatigue or aches and pains creep up on you over the years, and it's difficult to pin down when they might have started, but you feel better when they stopped, and we've discussed that. And as I said, the mechanism of why people get these aches and pains and who might get them is just not understood at all. And therefore, it's hard to say whether they're similar mechanisms to what you might encounter when you first start the treatment. But
it's equally as important to mention them so they can be managed in some way, if possible.
Yeah, absolutely. You know, for some people, I've got one lady who's had to go back on imatinib because she had really bad aches and pains. I don't want to overemphasize it, because for most people it's not a problem, but for some people it is. And I've ended up in the curious situation where this individual doesn't really need the imatinib for the leukemia treatment, but her quality of life is impacted significantly by not being on it, and therefore she's better off on it, even though maybe she doesn't strictly need it for the leukemia. That's an odd situation, but it does happen occasionally. But it's uncommon. For most people, when they stop, they don't have these side effects, but it's just worth mentioning.
Yeah, definitely. And someone did ask that, so thank you for reminding me of that one. It's a very interesting question that I forgot a moment ago, that I know we discussed when we were having a quick catch up before the webinar. Someone's asked about what is known about the long-term impacts of TKIs and whether as patients survive longer and get older, whether some of these issues are related to age rather than to the treatment. Steve, what's your thoughts on that as a clinician?
I'm conscious of age. I climbed a thing called the Old Man of Coniston last weekend, and I felt like an old man ever since doing that. So age creeps up on all of us. And I think, as you say, Charlotte, we were having this discussion a little bit before. It's as a doctor, I'm always a little bit wary of saying, oh, it's because you're getting old, because, you know, many quite serious problems masquerade as just, you know, the features of old age. So yes, of course, you tend to get more aches and pains and things as you get old, but these medicines can cause that as well. So being open-minded and alive to the possibility it could be a drug-related side effect rather than just old age, I think is the starting point for this. And if you've tried stopping it and it hasn't improved, and there are other features that might explain your aches and pains as being aging related, then fine. But you know, we know well that these medicines can cause various problems that might look like you're getting old, i.e. fatigue, aches and pains, that kind of thing. And I think it's up to patients to demand of their clinicians that they investigate it properly and consider it properly, and up to nurses and doctors to think about it and whether it could be medicine related rather than just getting old.
Yeah, indeed. I often hear from people who are subsequently diagnosed that they put the symptoms of leukemia itself down to getting older, which I don't think people should immediately make that conclusion. I hope that changes at some point. Nigel, I'm going to put the spotlight on you because I know you asked this question beforehand. What are your thoughts on this topic?
I mean, I think Stephen's sort of covered it really. Yeah, well, I think you've covered it. I've been on treatment 10 years, and therefore, I've gone from being 45 to being 55. And whilst, I'm still reasonably fit and well, given another 5 years, certainly another 10 years, and I become 65, and I'm absolutely certain I'm going to have aches and pains that I haven't got now. And I think, Steve a second ago made a very good point, actually, because maybe I'm too guilty of putting them down to old age. And if I gave you the analogy of diagnosis, we've all been here, I was having night sweats. Well, it's summer. I'm losing weight while I'm playing a lot of squash. No different than getting older, really. You just accepted it that, no, I haven't got CML. I'm just stuff, isn't it? So I think that's a very, very valid point that Stephen said. It's very easy to think, actually, I'm getting older, let's put it down to that, but it may not be. It may actually be your CML related. So I think that's probably what I would add.
Can I just say one more thing, just on this topic, that it is worth making sure with us, with your team or with your GP, that other basic things, that if you took CML and you took TKIs out of the picture, have been properly looked at. For example, your ferritin level, thyroid function, other normal things that can happen to everybody, to make sure that they have been looked into before you attribute it to what is looming largest in your life.
Yeah, I mean, Joanna, if you don't mind, there was a very similar question about this in the chat. Someone was saying they've got a diagnosis of CML as well as fibromyalgia, which is obviously also a chronic condition, and they often struggle with their GP in terms of supporting those two different things at the same time. I'm guessing it's becoming more common with people living longer with CML. They'll have multiple illnesses, and how do you deal with that as a clinician and with patients?
Yeah, it's not easy always to tease apart what causes what, and certainly when as conditions like fibromyalgia are being more and more recognised in primary care, anybody would be hard pushed to say exactly what symptom pertains to what problem. So I guess you can look into changing and dealing with what you can, and like all medicine, it's a little bit of a journey of trial and error, and balancing what works against what's tolerable. And it's not, things are very, very rarely fixed in one go, and it's often an ongoing conversation and an ongoing process to see how best you can what the best outcome you can end up with is.
The question also sort of asked how to help the GP, and if you were to be approached by a GP saying, I'm not quite sure whether this is related to this or that, is that something that you routinely help with or can help with?
I mean, occasionally we do have very engaged GPs who do get directly in touch with us to ask questions exactly like that. We can say what we know, which is, what side effects we'd expect to see on the TKI that the person's on, what the alternatives we can offer, and what is associated with what other condition they are managing. And then again, it is, it's a conversation about what can be tried, what wins there are to have. Sometimes it's about managing expectations, and sometimes it's about, come on, we can do better than this.
Great, thank you. I suppose we should move on to a little bit of an elephant in the room. We've had a few questions related to obviously COVID-19, and maybe David, I want to start with you, if I may. There's been a few questions about people people saying, "Oh, COVID and the CML has stopped me from doing this during the pandemic." Have you seen a lot more people sharing their frustrations because the pandemic has perhaps meant that their CML has come to the forefront when it wasn't before, if that makes sense?
Yeah, I mean, we all, well, not all of us, but most of us, I think through some clerical errors, got, letters to shield. Whether that's fully appropriate for somebody who's like Nigel or I, who's 9-10 years into their CML journey and doing well, that's a kind of a debate I think a lot of patients had with themselves and with others. Some patients very keen to say, I feel fine, I'm just going to sort of take the guidance as if I was any other member of the public, and I'm not going to specifically shield. Other people very, very concerned, and wouldn't want to go out of their house and would follow the shielding guidance very strongly. So I think undoubtedly that's impacted on people's quality of life. It's certainly, for somebody who may not really think about their CML and just sort of pop the pill every day, because you've gotten to that point where it's not a big thing in your life anymore. All of a sudden I've been told because of it, you should be shielding and taking extra care, I think might sort of bring some of that sort of back to the fore. I mean, my own way, I did shield for the first while because we didn't know much about COVID at that point. And then as we sort of know more, and then as vaccinations have come through, I'll be a little bit more more towards the standard guidance for everybody, I guess. But I think, yeah, it certainly has worried and concerned a lot of patients of how they can live a decent quality of life under either the worry of getting COVID and what that might mean to them if they got it, or just the restrictions that might be in place.
Yeah. Well, somebody asks quite simply, does CML make me more prone to catching infections? Which I suppose has become a even more important question during this time. And Steve, do you want to answer that from a clinical perspective for us?
Sure, I'll do my best. I think the first thing to say is we don't know. And I think so many of these questions that people have, and you can imagine, especially with vaccination and the new clot story that's going around, we get calls every day in the hospital from patients who are concerned about whether to have the vaccine or relative risk and all that kind of thing. For most of those things, we don't know the answer, but we have some idea of risk and benefit. So I think there's a tension between, and David has described it, between the official line of the government, which is that patients with CML on a TKI, and it's specifically mentioned in the shielding guidance on a TKI, are highly vulnerable and should shield. So throughout the whole of the pandemic, I felt the responsible thing to do was to toe the line there with that. And that might mean lots of people are shielding unnecessarily, but because we don't know the risk, I think it's wise to be cautious. So that's point one. Point two here is, do I see lots of patients in my practice who have CML and a TKI over many, many years? Do I see them having apparently excessive rates of infections? Answer, not at all. So I really don't have that impression of seeing people who are susceptible. And there are, of course, lots of patients with different types of leukemia. People who've had a bone marrow transplant, who are on steroids, who have no neutrophil count, etc., who are clearly more at risk of infection. But I don't seem to see that in my patients who have CML. But I think the party line is the one to be followed, which is you should shield, I think, when the government recommends that. And fortunately, of course, that shielding requirement or recommendation has been dropped relatively recently. And as David mentions, we're doing pretty well in this country with vaccination. And to kind of head off that question that might come up, and it's come up lots of times at my hospital, I've got CML, should I have this vaccine? Answer, absolutely yes. If you look at the risks of the vaccine, even with this latest story of odd clots that people are having, the benefits, especially in older people, and most patients with CML are slightly older, the benefits and risks are clearly in favour of being vaccinated. So I personally, if I was in that situation, I'd have no hesitation, and I strongly recommend to my patients with CML that they go ahead and have the vaccine.
Thank you for clearing that up. Nigel, I want to come to you. So I have a recollection that you were working on a study of the impact of COVID on CML patients, and I wondered why you felt that was important to do and what you sort of expected you were going to find with that. Why did you feel like that was a sort of a necessary thing to participate in?
That's not quite right. The survey and the paper that's been put together was by myself and Nick Duncan at the QE and a couple of other people, and it was to do with clinical appointments and attending clinic against online rather than anything else. So I say it was a completely different thing, and actually the feedback from it, and it has been and is being published, was generally very positive by patients. People actually quite liked the ability to have remote appointments. I'm not going to go over what we discussed earlier on, but attending clinic first of all, and so no, it was a different thing, Charlotte. Really, sorry.
No, that's fine. I remembered as soon as I said it. But I think that comes back to one of the biggest impacts.
One thing I would just add with the shielding though. I didn't particularly shield, and everyone's circumstances are different, because I think some people had to not shield because they have to go to work. Have to is a very wide word, depending on what job you do and whether you're self-employed or whatever the case may be. So I think for those people who have gone out there, then, you know, fortunately it has turned out to be okay for us. But, you know, anyway, sorry.
Yeah, as I was saying, I think this the remote monitoring thing is one of the big changes of COVID, and again, we'll not go over it again, but that's probably one of the things that most people have experienced a change in terms of CML. Where was I going? I think I don't want to labour on COVID, because I think there's a couple of other things that we wanted to cover, and one of them was around diet. Maybe, Nigel, I can come back to you and just ask you to expand on what the most common things you hear in regard to diet are from other patients and where the confusion lies around this.
Yeah, I think it's not particularly diet as such, because I think we all know that we should be eating, you know, as healthily as we could. It's probably more what you are and you're not allowed to have. And I think, you know, the big no-no is the grapefruit one, which is applicable to a lot of different drugs out there. And then you start hearing things about blood oranges and about tea and different types of teas and all the other bits and pieces. Again, I think a lot of those lists that are given out by hospitals or online, and can be quite generic, really. For the vast majority of people, within reason, as long as you have a healthy lifestyle, then you can pretty well enjoy whatever you want to enjoy. The grapefruit is the big no-no. Other than that, and, you know, and it's probably Steve O'Brien who can say if there's anything absolutely definitely that you shouldn't be taking with your diet, but look after yourself.
Anything you want to add then, Steve?
Nothing to add. In my life, not having grapefruit juice is not a great miss. I'm not a big fan. I'd be a bit upset to not be able to eat oranges, but grapefruits I can live without. And you know, there's a very well established biochemical basis of that. There's something called bergamotic acid in grapefruit that messes up drug metabolism. So really, for most of the things that we all enjoy and like to eat and go out to restaurants and have and what have you, including the odd glass of wine or beer, God forbid, I think it's fine. So yeah, grapefruit's the obvious one. For everything else, just eat well, eat healthily, eat normally.
Joanna, I've got a specific question about vitamins, and I think it comes into something you were saying earlier about you know, staying healthy in diet, and Steve just reiterated that, but they're asking if they can take vitamins safely with their TKIs. I assume the answer is yes, based on the previous answers, but just want you to clarify that if you could.
I don't think there's there's any contraindication towards taking any vitamins, but I would say to people, don't go and spend a lot of money in Holland and Barrett on a shopping spree for vitamins. If you want to take one, a simple multivitamin will probably suffice. If your body doesn't want it, it will just pee it out, and that's your cash, literally down the toilet. So we can tell by your bloods, whenever we see your rough overall health, you will know if you eat fruit and vegetables and everything else and get a little bit of sunlight every day. I think if you live a relatively healthy enough life, a simple multivitamin, if it gives you reassurance, will suffice.
I think one, Joanne, that we often get asked, and we see people asking on our various forums, is, if I give up meat and eat loads of kale and take these vitamins, will that make my PCR number drop faster? A really common one. I think people want to feel they've got control over it.
Sure.
Is where it comes from.
Absolutely. And I think, as human beings, we want to do that. We want to do the things that we can do. And I think that's really good to concentrate on. I think that there's a lot of evidence that a plant-based diet full of fiber, fruit and vegetables improves your overall health, as does additional exercise, as does what is often goes unmentioned, which is finding opportunities to de-stress, to relax, to practice meditation and mindfulness. All of those things contribute towards leading a healthy life. So they are certainly things that we all have within our power to do. And I would advise you to concentrate on that rather than dip your toes into a very big multi-billion-dollar industry, which is the alternative health industry, which can, is often guilty, and not entirely, but it's often guilty on playing on people's emotions and advising things that people don't necessarily need.
Thank you. There's one question that's just popped up, so I might as well ask it while we're on the topic, asking about pain relief and over-the-counter pain relief. I mean, I'm getting the impression that that's not something that's an issue either, since you haven't picked up on it. But again, if you wouldn't mind clarifying that would be great.
Should I take that one, Charlotte?
Yeah, sure, please.
Sorry, John. Do you want to feel that one? Okay. Two quick things, and it's not a big problem, but paracetamol, there was a bit of a concern about many years ago because it's liver metabolized, and so is imatinib. So you shouldn't avoid it at all cost by any means. If you've got a headache, taking a couple of paracetamol twice a day for a day or two is going to be fine. Taking 8 paracetamol a day for 6 weeks it isn't probably not a good idea. It wouldn't be in any circumstances really. There'd be some other better medication. So paracetamol generally fine for the odd headache. These medicines, sometimes imatinib, can irritate your stomach a little bit, and things like aspirin and common arthritis type medicines, or even over-the-counter things from Tesco like Brufen or ibuprofen formulations can do that. So as in many things in life, all things in moderation. They're not absolutely contraindicated, but I would use them with some caution. And if you feel like you've got indigestion on some of these medicines, probably stop them.
Great, thank you. We've covered an awful lot today, and we are almost at the end of our time. And there was a couple of people have asked for advice for the newly diagnosed. And I think that's quite a nice little place to end this talk, if I may come to each of you. Apologies for the banging and crashing in the background there. So yeah, I think we'll start so we can let our patients have the last word. Maybe Steve, if you could start on that question. If you had someone in front of you who's newly diagnosed, what do you say to them when you're in the clinic in terms of learning to live well with CML?
The first thing I say to people who are usually very frightened in this situation is, chances are you're going to be okay. The story in CML, for those who are not as expert on the call as some others, it's a remarkable story over the last 20 years, and it's a fantastic testament to modern science, technology, and medicine that we couldn't say this 20 years ago, but we can now say that for most people with CML, their life expectancy is going to be the same as if they didn't have CML. It's normal, and that's an incredible thing to be able to say to people, and it's true. Some people still unfortunately die with CML, but it's really quite uncommon these days. And I therefore assure people that they're going to be okay. Then I think it's the point I made at the beginning. You know, the focus in the next 3 to 5 years or 10 years, 20 years is going to be in quantity and quality of life. So I think we can be fairly reassured that lifespan is likely to be normal. So my focus really is on quality of life and making sure that we choose the right medicine at the right dose for people in order to get the numbers which are good enough. They don't have to be perfect, but allow them to get on with their life and do things that they want to do without having to worry all the time about whether they're doing okay from their CML. But it's generally an optimistic message, I think, Charlotte, that with modern medicines and the choice of medicines that we have now, the prognosis and the outlook is really very good.
Great, thank you. Joanna, if I could come to you next.
Yeah, I would say something very similar to Professor O'Brien. I guess probably I would counsel people that, you know, it's absolutely normal to feel really quite shocked and to feel like you've lost your footing a little bit in life, and to be very compassionate towards themselves. Tend to be a little bit cautious before offering a very optimistic picture, because I feel that sometimes for those few people for whom it isn't such an easy ride. It can feel doubly bad not to be in the vast majority of people who do very well. And so tend to sort of leave the more optimistic side of it until we have a much better picture of what our initial upfront diagnostics tell us prognosis is likely to be. And then we'll take it a day at a time. And I think just making sure that they know that they're not alone, that their nurse, their doctor, our counselling team, our dietitians, our fantastic staff who help all cancer patients are there to support them. And although it is going to be, you know, probably 3-6 months, a year of can't take that worry away, that we're here and we're going to help them through that.
Forgot to unmute myself, apologies. David, carry on, you were going to speak anyway.
Someone newly diagnosed, I think there's a couple of things I'd probably tell them. One is to probably, I think Joanna mentioned, give yourself a break. The mental challenge and difficulty of dealing with the CML diagnosis can be a lot and can be really underestimated. And you might be feeling all sorts of different things at different times for quite some time. So to go easy on yourself. The second thing I think I'd say is find whatever way you can to get more comfortable with your CML. For me, that was learning about it in as much detail as I could. For someone else, it might be a bit different, but find your own way. And I think lastly, as Nigel kind of alluded to this, you know, patients will go online and will look at forums and will read things. And just to be really aware that the stories you read on online forums are not typical. Most CML patients who are doing really well are, you know, kind of on the topic of this, are living well with CML, and they're out there getting on with their lives. And they're not checking in to say, hey, everyone, today was pretty mundane. I went to the gym and I went for a walk and had a glass of wine. They're just going out and doing it. So, you know, if you looked at the CML forum, a new patient might be really worried because they see some terrible things, but that's a small slice of the overall patient group.
Nigel, carry on.
Yeah, I think actually what David said there is a fair assessment. Bear in mind, people on summary on groups are generally there because they're relatively newly diagnosed. I mean, it's interesting, after 9 or 10 years, a lot of the names on the Facebook group, which were posting daily, multiple times daily, gradually become weekly, gradually become monthly, and gradually vanished. And that's great because they don't need that support there. So yeah, I think that's a very, very fair comment. If you're newly diagnosed, you're more likely to see a lot of stuff out there because you're newly diagnosed. As time goes on, it gets easier. Family and friends, I don't think it's particularly been mentioned, but if you are able to share your illness, and some people are and some people aren't, most people are, take the support that's offered by family and friends. I think that's very important. Be optimistic about your future. and I think more than anything, live life. And, you know, for certain people, things have changed massively. You know, when I was first diagnosed, you could never stop treatment, and we've discussed that. I'm not going to go on to that again. But what is very, very interesting, and this is only applicable to younger people, is that, and David is an absolute living example of this, is that, you know, for CML patients now, if you're a younger person, you know, you can go on and have a family even. You know, 10 years ago when I was first diagnosed, the thought of actually having a child other than by accident was not a chance. And, you know, that's changed. So things are okay out there for the vast majority of people.
Yeah, you're right. We haven't even touched on things like pregnancy. There's so much more we could have talked about today. Some lovely messages there, Ian. Thank you, everyone, for your time today. It's been really interesting. Apologies to anyone we didn't get to answer your questions. I think there's only a couple. I'll try and make a note and get in touch with you afterwards to make sure you've got all the information you need. Just a reminder that you will get sent this webinar, a link to a recorded version in your emails afterwards. So if you need to go over anything, you can do. Just a quick reminder of everything else we've got going on. I wanted to mention our next webinar. I've not put it on the slides, but our next one in CML is focusing on treatments and the different treatment options and when they're used and at various times through. And we're going to do first line and second line. So second line and future line. Sorry. So whatever TKO you're on, or wherever you are in your pathway, please do join and listen for that one. Next slide, please. Ooh. Cool. Just wait for this to come back. I think so. The slide that was going to be there is when my colleague finds the slides, was about our podcast. So we do actually have a podcast as well, where we share stories. So if you've enjoyed listening to Nigel and David speak today, you'd probably also enjoy the podcast as well. There we go, which you can find by searching on our website or on any sort of apps that if you've already listened to podcasts, you'll find us on there by searching for Leukemia Care. Next slide, please. Thank you. So this is just a slide summarising our support services. The one I'd like to point out in relation to today's webinar, next slide, please, is the Counselling Fund. And we've talked about a few emotional issues. And if you are looking for professional support, we do provide up to 6 sessions of counselling through that fund. So get in touch if you are interested in that. Again, there's a link there, or search for Counselling Fund on our website. Next slide, please. And I'll just leave this up. So if you need to get into contact with us, these are our contact details. Thank you again to all our panelists. It's been a really great discussion. We probably could have talked for another hour and a half. I'm sure we'll have them back at another time as well. Thank you for your time, and we'll see you all at the next webinar. Thanks, everyone.
Cheerio.
Thank you.
Bye.
Bye.
Bye.